A lot of people get psyched out when we're talking about medical legal because there's a lot of like, what if I do something wrong? Do I get sued? How do I manage that if there's something, a case brought against me, and how do I minimize that possibility? And so we should take some time to go through the things that we need to preserve when we're dealing with emergencies, basically people's identities and whatever their medical emergency is. But there's some weird gray area there. So like, how are we allowed to tell the hospital staff and the family about the patient if it's their personal information? How do we use some of those paperwork stories and scenarios in class, even though we're now talking about a specific patient we had? How are we allowed to get around those parameters? As I mentioned earlier, there might be patients that are A&O times 4, but they have some kind of life-threatening emergency, and they're just being stubborn, or they're not making the right decision, or they don't know what's going on, or they're superstitious and paranoid about going to the hospital. And for whatever reason, those might all make sense and valid, and you go, that's fine, they're just stubborn. Sometimes, though, there's an underlying life threat that you, as an EMT, need to ensure that you take care of for that patient. And so sometimes you have to go and find some ways to manage that patient for their best interest, despite some legal, some gray area or some red tape to go through. So we'll talk about all that stuff in medical legal. I'll just start it off by saying a real easy way to remember this is that you're being a patient advocate. You're doing what you're doing to keep them alive and to keep them healthy. And you're acting in their best interest and yours without trying to get any compensation or do something outside of your scope of practice. You're going to be fine. There are some situations that get dicey, but then at the end, actually it worked out for everyone's advantage. So I'll bring those in as we talk about this. So we'll talk about consent, what exactly consent is, how people can refuse, what confidentiality is, and what act preserves that. Anyone know that offhand? That's the HIPAA Act. So we'll touch on quickly. Advanced directives, DNRs, pre-deciding what you should get, what treatment you need if and when you have a cardiac arrest or you are knocked into a coma. How do we manage those patients? Any kind of tort versus criminal law that we need to consider. Evidence preservation, some responsibilities, what you have to report on, some medical or ethical principles and moral obligations, and end-of-life issues. So, as I said, remember in the beginning of this, Hippocrates, his number one saying was primum non nocere. First, do no harm. This was back in the day when they were like bleeding people and stuff. The idea was you're trying to save someone's life. They're already in a bad way. Don't make it worse with whatever treatment you do. Act as a patient advocate, and that's what's going to get you through most of this. So according to the Health Insurance Portability and Accountability Act of 1996, the HIPAA Act, we're not allowed to speak about anyone's personal information. We don't bring up their name or date of birth or their address and tie their name or their date of birth to their address if we're talking about a call. We don't have the ability to speak on the phone or on the radio about that. So, mind what you're saying over the radio, because technically it's an open line, even though there's probably no one outside of the fire department listening in on that. There's a possibility. And so you really do have to watch out for that. That being said, I know tons of times where I've had people call in and go, hey, do you have information on Mike Frank? And they'll be like, yeah, he's been picked up 3 times for 5150. And they'll relay it over the radio. And you're like, you guys, do that? Yeah, it's fine. Bigger cities, there's just a lot of leeway more than a small town thing. So know your area. And that's another thing to keep in mind. Know what your agency expects of you. So here's the question. You're not allowed to talk to these people. Let's say you have a patient that is really an ambiguous patient. You can't figure out what's wrong with them. They're altered for one reason or another. You try oxygen. You try giving carbon dioxide exhalation. You're trying to, you check for their blood sugar. You give Narcan. That doesn't change anything. You go through all their medical history. Nothing is obvious as to why this patient would be altered. You check their temperature, no fever. I want to find out what that patient's outcome was. I want to find out why I couldn't figure out with all of my tools what was wrong with that. And my assessing didn't come up with a conclusive answer. Maybe if I find out what it was in the future, when I have a patient like that one or that one exactly with those similar signs and symptoms, I'll be able to treat and kind of understand, oh, this is hyperkalemia or something like that, you know? So if I want to follow up on my patient, am I allowed to call the hospital or come in off duty the next day and inquire about that patient? It's weird, right? No, we would mostly, according to the rules of HIPAA, should be able to just walk in and go, hey, I was the medic that brought in Scott Frank, and what happened with him? According to the HIPAA rules, that's pretty much not allowed. That being said, it happens all the time because we're in a chain. So there's some ways to reframe this. If you're in part of that chain of survival, we're there trying to find out, like I just said, there's a reason behind why I'm inquiring about it. It's for good motives. I want to find out if that run on this patient again or somebody like that. Maybe I can act better because I'll know what was wrong with them, with this particular patient at this particular time. What I usually end up doing, and this is pretty much an unwritten rule, is if you go into the emergency room, find the veteran nurse or the doctor and say, I'm going to call later tonight. You mind if I call and ask for, who should I ask for to find out what's going on with this patient? They go, yeah, here. Then you call this number and then ask for me. I'm Jeff. Then you call and you ask for Jeff and say, what was the deal? And they'll give you the information. Is it legal? I mean, yes and no. You're trying to figure out what's going on. I'm not going out and telling everybody about what's going on with that patient, but I am following through on the continuum of care. So there's little bits and pieces along the way, little ways that you can kind of tweak it in order for your motives to be the best and you're getting the most out of these calls. That being said, if I have like a PCR that I'm putting up on the board and we're walking through communication documentation, what would be things I'd have to blank out on the PCR, on the patient care report, that would give away who our patient was? Name, date of birth, address. Yeah. Sometimes it gets tricky. Like I'll say in Tiburon, we know who lives in certain houses. And if you explain a certain house, people know who's living in that. So I would avoid even mentioning what the house looks like or anything, any kind of identifying information. I'll give you another example. So we'd have to get rid of certain things. If we ever put a PCR on the board, that should all be blanked out. When you do your clinical ride-alongs, you're going to be filling out patient care reports for at least 10 patients. Don't put their name or date of birth on it. Just their gender, their age, their chief complaint, the treatments you did, the signs and symptoms, the assessments, and the outcome if you know it. And that's good enough. That's all we're really interested in. So that other stuff is ancillary. And yes, maybe it has to be addressed in order to get the information about them, but you don't then pass it on to somebody else. I'll tell you another story about two medics that had a pretty crazy call, and they dropped off their patient in the ER. They went into the elevator and they're talking about the call. I'm like, dude, there's shit all over patient. And she was fighting you and hitting you in the face. And he's like, yeah, I had to wash up. The patient's family was in the elevator. They didn't say the patient's name and they didn't give any identifying information other than they were talking in front of a group of people that knew they could put the causation on 2 and 2 together and figure it out. They didn't fare so well. That was a smack on the ass for them. Be aware, you should also know the company you're in and keep your mouth, know when you should be addressing these things and talking about it. Yes, you can decompress after the call, but not in front of the public. That just doesn't go well. Keep that in mind. It doesn't also, so the rule is, yes, you can inquire to a certain extent using names and dates of birth for the right reasons. And you can still follow these rules and get in trouble if you're using it in the wrong ways. If you're, well, they didn't say anything about who they were, the date of birth. Yeah, but somebody can put 2 and 2 together and figure out what you're talking about. And you shouldn't be doing that in an elevator anyway. So know what you're doing when you do this. Just a little self-reflection goes a long way. Okay, so consent. We need to get consent to treat. Again, that's like the formal rule. If someone is 804, they need to allow us to treat them. ANO times 4 happens in the general impression of the primary assessment. Do they know these 4 things? Who they are, where they are, when they are, and what happened. And based on those, they can say, yes, go ahead and treat me, or no, I don't want you to treat me. Express consent is exactly that. You walk in and say, hey, I'm an EMT. And they get a blood pressure and a pulse. Is that okay? Yes, go ahead. And you start doing vital signs on somebody. They allow you the express consent. Now, technically, calling 911 and saying, I need someone here to help me is express consent too, right? So you don't have to walk in and go, is it okay if I get a blood pressure? Is it okay if I check your pulse now? Is it okay if I check your respirations? If we go in and we see somebody in duress, I'm going to just start treating. And we start asking questions and getting to work. My buddy's going to get a blood pressure and everything. And people they're going along with it. That's enough for that to be an express consent. They're going along with your treatments. So you don't necessarily have to ask permission to do everything. It's only when they start backing up and saying, no, I don't want any of this. I'm not paying for you to do the treatment on me. I know there's costs and I don't want to go in the ambulance. And now you're kind of stepping back and saying, well, what would you want us to do here? Can we check your vital signs? Can we find out what exactly is going on? And then we can make a more informed decision after we have a better show. If they're not able to give express consent, and I haven't said no, but in other words, they're either unconscious, they maybe have a stroke and they can't speak, or some other reason, catatonic or something where they can't tell you, implied consent is what we follow. It's implied that they would want us to treat this patient. They can't say, yes, go ahead and treat me. Somebody's parent fell out, they're unconscious. We're going to go treat the parent. We're not going to worry about, you think they'd be all right with us if we treated? But
on the last slide, you had expressed and informed for those.
Same thing, you're informing. Yeah. You're informing with it. Your express consent or informed consent. Good. So this is also the implied consent is also what you would call the emergency doctrine. It simply covers us to walk up to a stranger unconscious on the street, man down is what they're called, probably person down in some places now, but there's somebody on the ground. We don't have to have a warrant to start going through their pockets. We're treating them. So we have under implied consent or the emergency doctrine, we're going to start working on that patient to find out why they're unconscious and if we can do anything to help them. That's what you would imagine if they had all their facilities, they would want us to do. It would say, yeah, I'm not feeling good. I'm passed out. Work on it. Okay. That also is kind of what they'll call the Good Samaritan rule. That kind of flows into that, where as a Good Samaritan, you're treating patients and there's kind of a little bit of security and, you have some safety to work on people and treat them. If they wake up and start getting angry with you, it's like, well, I'm just trying to be a good Samaritan. I'm trying to help. I didn't know this was going to make you upset. I was trying to make you better. So it all kind of falls under that umbrella. Then you get into some situations where the patients are actively denying they don't want you to treat them, but they need to be treated. So what are some examples? I'm sure you can think of a million of them, but what would be a common reason we got a patient like this freaking out and we need to get to them, but they don't want us to? Drugs, yeah. Mostly any alterations. So actually, if you look at the AEIOU and tips, which we'll get to in a couple of weeks, alcohol, drunk, yeah, coming off of alcohol, withdrawals, epilepsy, after they wake up, right? Insulin, hyperglycemic or hypoglycemic, usually hypo, you're altered, you're combative, head trauma, yeah. All of these things can indicate somebody that has a serious underlying emergency, but they don't want you to treat them. In which case, we're covered under this involuntary consent that because they're either mentally ill, they're in some kind of behavioral crisis, they're developmentally delayed, head traumas. So for some reason, they're non-compos mentis. They're not capable, they're not ANO4, we can treat them. We can work on them. In fact, not only can we treat and work on them, we can restrain them too. So we can use restraints. This starts to get into some weird situations because with someone who's altered, yes, you can use restraints. Somebody who's ANO4, let's say a suicidal person, that is a 5150, that is a danger to themselves or others, but they're ANO4. Now, are we allowed to just put them in restraints and take them to the hospital? What's that? You need cops if you're going to go with a 5150 hold to get somebody to the hospital. If they're ANO4, but you're going to get them there, you have to watch out. Taking somebody against their will is technically kidnapping. Threatening to touch and treat and manage and put them in restraints without their consent is assault, and actually doing the treatment is battery. I know it's a little bit weird. It's a weird, you like actually threatening, like you get in, or we're calling the cops, and but like strong arming somebody just verbally can be assault. Battery is like grabbing them and throwing them in, and then like working on them, and they're like, no, you do blood pressures on it. So if we need to forcibly restrain a patient and they're ANO4, we have to put them on what's called a 5150 hold. It's a psychiatric hold for up to 72 hours. Usually they don't go the full 72. They get processed and they go to a psych ward before that, or they get released, or whatever happens before that. That 72-hour hold, just for your own understanding, can be, you can file another one afterwards and they can be held for another 72 hours, and that can kind of go indefinitely. But the initial 5150 is filed for somebody who's a danger to themselves or others, and it has to be done by police. It's a legal arrest that's being made on somebody who's has all of their awareness and doesn't want to go, but they don't want to go because of maybe the reason why we're there, right? So if they're suicidal, they're not going to be safe if we leave them at the home. And in there, kind of, there's some weird areas where we can say, well, how altered is this situation making them? What if this was like a patient that was having a heart attack and they're like passing out and they're like, I'm not going. But every time you ask them ANO times 4, they know it. Can we take them to the hospital? Is it smart to leave them unseen? We can clearly see, you've seen signs and symptoms, cool, pale, diaphoretic, sweaty, passing out, their blood pressures skyrocketing or dropping, their pulse is all over the charts, irregular. They're coughing up like that pink sputum, and they're kind of looking at you like this, but they know their name and date of birth and where they're there and why we're there, and they don't want to go. What the hell do we do there? Yeah.
Wait 30 seconds for them to pass out.
Wait until they pass out. Go, okay, cool. All right. Wait, and just be like, every second we wait, you'll get further and further away from us being able to save you. But go ahead. So there are certain things that we can bring in to try and convince people to go. And so I'll just briefly mention them now. We can always call the base medical, someone who's there as a doctor 24/7 to ask advice or pass the phone off to the patient to have them speak to a doctor. Oftentimes that's all it needs. The doctor is a medical professional that is, in culture, a much more respected person than somebody on an ambulance. So you might be arguing with a guy for 10 minutes and then you start here, the doctor wants to talk. He goes, oh, really? Okay. All right, I'm going. You're like, what the? Okay. That's one way. What are other ways of getting somebody to come with you without having to put them in forcible restraints and making this into a legal issue?
Explain to them the situation.
Okay. Like how?
What might happen if they don't.
Okay. Yeah, absolutely. That's a great way of doing it. And start, everything we're seeing here is serious. I wouldn't make you go unless I thought this was important. As a trained professional, every sign of symptom I'm seeing here is life-threatening. And that can turn into like, look, you're going to die. And this is clear. I'm not going to lie to you about this. This is bad. And I don't want to wait this long. So let's go. You're going to die if you don't. You understand? Okay. So that's one easy, too hard way of trying to convince somebody. What else? Yeah. Family. Ask a family member who's there. Look, your kids are freaking out. Can we just go to keep this chill? You're going to come back to this one, later on if you're lucky. So let's incorporate the family members and see if they can talk them into it. So all of those are our way. Now, there still might be nobody there. They're on a bus, and talk about that after when we have a break, because I have some good stories about that. Depending on the medical director of your agency in your county, they're going to have a different opinion about how to manage those calls. So we should talk about that in this little scenario in a minute. Okay, I want to go back though. We did touch on minors. If you are dealing with a minor under 18, you have to ask the parents' permission. They're the legal guardian. Parent or the legal guardian is the one that makes the decisions for the kid until they're 18. What if you can't get in touch with the parent? Don't overthink it. Just do the treatment, take them to the hospital. I would imagine it's kind of that like implied consent, but with the minor as the subject, the parents are going to want the kid to get medical attention. So take the patient in, don't worry about it. That's probably going to be that, that's the responsible decision. If the patient is at school, or maybe it's like organized sports or something, remember as a kid, you had to get those release forms signed and your parents filled them out and brought them to the coach or to the school nurse. That basically says if the parents can't be contacted, the school makes the decision. And what do you think the school is always going to say? No, we don't want that responsibility. Take the patient, take the kid. You can get consent from a parent over the phone. You can get you can get it either in person, written, or on the phone. If you can't get that, get a witness to sign for that patient too, and just say this is why they decided to go. Patient's hurt, couldn't get in touch with the parents, so we decided to just take the patient. It again could get dicey if it's like maybe a patient whose parents are like the Christian Scientists, don't believe in medical care, and you're seeing somebody who's dying. This kid's maybe got a raging infection, or they've been hit by a car, and they're like, no, we can't take our kid. We don't believe in it. What do you do then?
Try to convince the parent.
That's good. Somehow.
Maybe explain about what's going on with the kid.
Yeah, this is the stuff of like TV dramas. It doesn't happen that often, but this comes into the last part of this chapter with which is like, what are your ethics? What are your morals involved with this? What are you willing to do as a patient advocate with enough information to know what's going to keep a patient alive, while still trying to preserve, that's the First Amendment right to religion. That, you're infringing on somebody else's rights. So that could go high, like Supreme Court high. Probably won't, but this is what we're up against. This is something that you might come across. It's nice to have base on the phone to document. It's nice to have a good crew with you that can get your back on that. And, and just having enough time under your belt and enough confidence and courage to make the right decision is sometimes all you really have. So more on that later. Now, also I want to mention, you can have a situation where a minor under 18 is actually emancipated and they make their own decisions. And the big couple ones are married, under 18, but married in the armed services, where they themselves are parents. So they have a child, they now have to be responsible for themselves and the kid, and the parents no longer make those decisions. I think like sometimes kid actors become emancipated because their parents steal all their money and then they have to go litigate, basically become an emancipated minor. It's kind of a rare exception, but these are the ones you run into. I think I've maybe 3 emancipated minors is what we dealt with, that this ever becomes an issue. Yeah.
What kind of proof do you look for?
What kind of what?
Like proof that they're.
They have paperwork. They have documentation that says they're an emancipated minor. Yeah. So there will be, and maybe a clinic or something where like they're being treated, they're a young mother, and the clinic's going to have documentation. They should have the documentation. It really doesn't come up unless it's a young kid who's under 18, who's got an injury that we think needs to go to the hospital, and they're saying, no, and I'm an emancipated minor. There's a lot of stipulations there that we don't come across that often, but it can happen. So those are the things we need to know more or less for National Registry questions versus real life. These are the solid or rigid restraints. They're leather and they have some cloth inside, actually really soft, and they work great. And the best way to do this, we'll go over it with psychiatric and behavioral crises, emergencies. Arms flat, straighten out, anatomical position, get a backboard, strap them onto the backboard like this, arms down. So you can get a blood pressure cuff on, so you can start an IV here, give meds if you need to, treat the patient face up, and then you have them on a backboard with restraints. You put some straps on them, like the spider straps across that. And then if they're spitting or biting or whatever, we have these little spit socks that are like fabric, like our screen, like a fabric screen that's just got a little elastic, loose elastic band they put over their head so they can breathe very easily, but they can't spit at you. They can still bite you, so stay away from that. And then we take them to the hospital. And once you get them there, you have them on this backboard on your gurney. And rather than having to take off every strap and move it from the gurney railing to the far gurney on the hospital bed to the next one, and you have to like move each one over, you just pick up the backboard, put the patient on it, and drop it down. You get out of there. You go, good luck with all of that. So we'll probably practice that once or twice. If you work, depending on the city you work in, like in Oakland, I did that, I think, at least a dozen times the first year I worked there. Like once a month, we were doing that on patients. It was crazy. Yeah, it was right when, before the opioid stuff, there was a lot of crack and ECP. So that you'll see it runs in waves. So you'll get like, remember, I don't know if you remember, but like, late 80s, early 90s, there's a crack epidemic in the world. It was a crazy New Jack City, like it's all about crack. And it was those kinds of crimes where, violent felonies and people were in hysteria. And then it will dip down into the heroin thing. And then it comes back up. And it's like uppers and downers. Depends on the thing, but usually it's a trend. There's drug trends in culture just like anything else.
More drugs. Is that more of the like instead of like you are basically out of your mind, you need the hospital? It's like a perfect thing, or if it's you're chasing people down the street.
Yeah, if you have a patient who's
you can't get end up like I'm on drugs, please tell me.
Yeah.
Chasing.
Yeah, and usually, so if that's going to be the situation, you got a patient, somebody called for them, right? Someone's like, there's a crazy person walking around running into traffic. They didn't have to be that. They could just be sitting there and shouting, and eventually somebody calls 911 to say, somebody do something about this. Firefighters, go. And if it is something, first off, that is dangerous, who's the first person that should arrive on it? Law enforcement comes. They clear the scene. Those are the calls. You pull up and you're in staging. And about 20 minutes later, they're like, you come in code 3. We got the patients. Clear, it's clear. And you drive in and they have them on the ground and they're like, give me the backboard. And you're like, okay. And you strap them and it goes like that. When you get called in right away from staging, it's going to be a hot scene. It's going to be pretty chaotic. So you go in and you strap them, but already they're a danger to themselves or others. They're 5150. In fact, there's another thing called a 5170, which is the same idea, but it's due to drugs or alcohol. Everybody just files the 5150s these days, but there used to be a 5170 as well.
You always have to follow 5150. You want to get a patient arrested. Like what if unless they're all police show up and already arrested the person and they need medical attention?
Yeah. So if that's the case, okay, so you will go on that. They're under arrest. The police have custody of that patient. We're just medically clearing them in those situations. So sometimes there'll be a scuffle when the patient gets arrested. They hold them down, and then there's like skinned elbows, and they're like, I can't breathe. And then you show up, and it's just they're like, they don't want to go to jail. A lot of times, sometimes it's legit. They can't see what happens when they breathe and you're being held down long enough. Sometimes it's just to clear. You make sure that they don't have to go to the hospital first, and then they're going to go to jail. So sometimes people will like have a panic attack and be like, I can't breathe. I'm having an asthma attack. I don't do well with emotions. And then you just show up and you're like, your O2 stat's great. Your lungs are clear. Everything's fine. We can take you to the hospital. Just understand that when the hospital clears you, you're still going to jail for stealing or whatever. It was the old days when they processed stealing. consult medical control if you ever have to do this. But the police will be on scene, so you really don't have to manage so much of the legal implications of it. It's allowed and you can do it. Let's see. Okay. How do we feel? You want to take a little break or keep going? Break? Keep going. All right. Let's do the medical bracelets and things like that. So that's consent. And let's talk about DNRs, medical alert tags, POLSTs and MOLSTs, POLST, POLSTs and MOLST, and medical jewelry. So this is what we're always looking for. That medical jewelry tag that's like a little oval, or I have some here as props. Just a little spare, like a square or something, you flip it over. On the side, usually it's got like the Star of Life or the Caduceus or something. So you know that's a medical alert tag, and you flip it over, it'll say name, sometimes date of birth, and whatever the emergency is that you need to know about. Often it's an emergency that's going to knock the patient out, which is why they have that tag. They're not going to be able to tell you. So anaphylactic reactions to things, epilepsy, diabetes type 1 or type 2. That's what's going to be on the tag. Those are the old tags. This is what they look like now. So when we do head-to-toe assessments, like everything on the patient, necklaces, bracelets, make sure you're looking on there and do your due diligence to find out if it is a medical alert tag, because there might be some vital information on there that we need to know. Remember, when it gets down to the very basic level, we're just doing airway, breathing, and circulation in patients. So as long as you can do that, you're in good shape. But it would be nice to find out, oh, this patient's a diabetic. In addition to giving airway, oxygen, and watching their heart and everything else, maybe we can give it some sugar and wake them up. And now lessen the damage to the brain because it's being starved of food. So once you find those little bits of evidence, we can go ahead and fix things a lot quicker. All right. So let's say you've had some experiences in healthcare. You've seen comatose patients on life support sit in the ICU for months while the family has to deliberate and figure out, are we going to pull the plug on this patient? Are there any possibilities that they could wake up? Meanwhile, you're racking up a huge hospital bill. And so you realize that can happen, and it can happen pretty easily if we follow some of these protocols that we have built into the system without any parameters built into it. If you want some parameters built into what can happen to you if you have, maybe you go into a coma, or you are brought back from the brink of death and you're now unconscious, you can get what are called advanced directives. And it's basically just deciding what treatments you want. And if it gets to a point beyond those, they can pull life support. Or if it's something that happens early on before you get to the ICU, we'll look for things like a do not resuscitate order, which is safe. Basically, it's an example of an advanced directive, but it's geared specifically for us in the field to know where our limits are when we're trying to provide resuscitative care. What do we do for most patients anytime there's cardiac arrest? CPR and the AED. That's your BLS care for don't forget oxygen, bag valve mask, like that. That's all BLS, basic life support care for somebody who's had a cardiac arrest. Beyond that, paramedic shows up, and what do? Start IVs. We can give epinephrine. We can intubate, open up the airway, really get oxygenation into the patient, pump them hard. We have the Lucas device that really can compress and move oxygen, does some damage to the body, doesn't always work, but we can provide that care. And every once in a while, it really works out to the patient's benefit. They come around, they come out of the hospital and they're alive, and they get another 15, 20 years. Sometimes it doesn't. Sometimes you just bring back, if you're hitting a heart, a newly dead piece of meat that's still got some electrical potential, and you're hitting it with basically adrenaline, you can get that thing to start beating. And this might be 10 minutes after the patient's stop getting any blood to the brain. And the heart starts coming back and it's mechanically operating just as like this life support systems, which eventually then feeds into the brain and it brings back your autonomic nervous system enough to start supplying you with digestive abilities and, you know, maybe even breathing, but not to a point where you're fully conscious. Now, what do we do with these patients? And that happens a lot, especially in elderly, especially when we're not doing early CPR and AED. So we're looking for things like DNRs when we arrive on calls. Specific patients will probably have DNRs. And so we're trying to figure out what point do we just not continue our efforts to save their lives. So an advanced directive is one kind of parameter of how you want this, and the DNR is a specific one. Who do you think would have a DNR? What kind of patients? Chronic patients, end-stage cancer patients, ALS, Lou Gehrig's disease, where everything's eventually dying up and you don't no longer have the ability to move your muscles, including your lungs, and you suffocate and die. People that are at the end of their lives are probably the ones we're going to be looking for a DNR for, right? They're bedridden. The DNR should be clearly near the patient, either on the clipboard by the bed or on the end table, so that we can get it and go, okay, we don't have to continue efforts. We can't find it, and the caregivers saying, well, yeah, they do have a DNR, but I don't know where it is. What do? We have to keep going. We go through cursory steps. We start, well, let's start CPR and let's see them find the DNR. Okay, then I haven't found one. Let's get the oxygen out. Paramedics should be calling base and saying, here's the deal. End stage leukemia, patient's skin and bone. We can't find the DNR. What do you want to do? They'll probably say, run 2 rounds of your treatment. And if nothing works with basic life support, call it. And we'll call it at that point. But it has to make sense for the patient. It's not going to be some 56-year-old triathlete who's looks healthy and everything, but the wife's like, well, no, he's got a DNR somewhere. Don't worry about it. Okay. He's probably got money too, right? Or yeah, okay. So be aware that that's what we're looking for, right? Be attentive to that. Yes, yeah.
You're calculating cold hearted distance. When there's 30 work to be done, you don't want to slow. Question number 4. Breathing at your own conscious with no muscular function. Was I able to communicate? So you had yeah, that's cool.
Yeah, you get like you're starting them over.
Moving on. You can involve a simple nervous system. They got a simple nervous system. Okay. And that's not my style.
That's it.
Yeah, it's sick. But I still go to the culture.
All right. So that's basically what you're going through with the advanced directives, not to that extent, but you know, you can decide on some things like you'll do all the BLS measures, but as soon as it becomes a situation where you have to start IVs, give meds, do any advanced life support, don't go beyond that point. So give me the chance. If I'm still viable off basic life support, off of CPR and AED and early defibrillation, then I stand a much better chance of coming out of that cardiac arrest with a lot more of my factors. Does that make sense? If you start going down the road of like, well, we can, and that's what we used to do. Like there was this period of time where nobody was measuring the outcome of these patients after we got them to the hospitals. So they'd say, hey, what if we give epi and atropine, and the heart gets back and suddenly you got this patient's heart working. We'd be like, we got a resuscitation. We got return of spontaneous circulation. And we bring them into the hospital and we're like, everyone's high-fiving each other. But it's essentially just the chemicals running through the system. The body is just running off of all of the drugs we pump through. And eventually it tapers off and they're completely unconscious, they're comatose. So we were kind of just pushing the problem on And eventually, this is through the 70s and really 80s. And then somewhere around that period, the medical directors, the conferences started saying, why are we giving all these meds just to make these people comatose in the hospital? Let's taper off the advanced life support meds and kind of make it harder for them to come back. So that if they do, it's more of the body responding to less care and it's a more healthy, viable body. And the chances of them coming out of the ER and out of ICU is much higher, actually, than just sending in a vegetable that's got a heart rate or something. All right, let's take a quick break. And I want to show some other things after that. Want to do that? Yeah. Hey, Troy, if you have a question, just take yourself off mute and you can ask it.
All right, thanks, Ken. Thanks for doing this.
Yep. Yo,
Have you ever had shopping shells and bullets exploding during the fire?
yeah.
We did on Friday, Saturday
Like in someone's garage.
in their house.
Yeah. Yeah, it scares the hell out of you. It's not doesn't have a lot of projectile force,
But there was like,
but it's like fireworks. Yeah, yeah. Wait, the last time I was on, it was a guy's. He was like a doomsday prepper, and his whole garage was full of cartridges, and the thing was like, and it was like hitting us. It's a little scary. Hey Troy, when I'm walking around, can you hear me talking, or is it really echoey?
Yeah, loud and clear.
Oh, good. All right. Well, maybe I don't need the microphone. I'll tell my wife.
Did you set up the camera over there? Or?
Camera's over there. Vocals are coming through the computer here, though. I do have a little lavalier mic that I use, but my wife grabbed it to do a lecture herself, a Zoom thing. So I just want to make sure it's not all echoey and hard to hear it.
Oh, it's perfect.
All right, cool.
Wasn't there like, there was like a trial last year somewhere. We was thinking about like two paramedics that went to jail because they treated somebody.
Uh, I'm sure it happens all the time, but I don't know which
Yeah.
one you're talking about.
Like they actually got like jailed.
Yeah, what did they do?
I forget exactly. I think it was like they arrived on scene because it was like police officers dealing with some person and they didn't do proper medical check on the person, and like the person died in police care. They were like, "Oh, he's fine," but they. I totally forget.
Yeah, that could happen. Yeah, what you'll will find out with this is like, did they do the amount of care that
Yeah.
that you know of? So if an EMT did it and they cleared the patient, but they didn't use like glucose checks, and that's actually a BLS skill now. So yeah, you'd be busted for that. But it's usually the stuff you don't do right that gets you busted. The things that you like slack off on. You're like, it'll be all right. Don't worry. Those are the things that usually come back to bite you in the ass. So that's why, like in class, I'm always so heavy on like clean up after yourselves.
Yeah.
You're tired. Good. Now you're in the level that you're going to be at the job. Like now make extra special care that you're doing the right blood pressures, checking pulses, you're doing all that, because that's when bad things start to happen. When people slack off, they get tired and like leave a guy. Like, and then you because you were lazy one night, you lose your career.
And that's the worst of their mates and then cop one. Shit, I guess. Yeah, I wear this, which is like attached to my watch.
Nice.
Talking about how they just blend in.
Yeah,
Right.
that's crazy. Okay.
And it's just so that if I'm biking in West Marin and get wiped out, there's at least a phone number to call.
There you go. And somebody was talking, they had the same thing, like they carry their phone, or the phone has that, or you have something on your watch, on your bike.
I ride with my phone in my pocket. If I get hit,
Better.
it's either shattered or it flies out.
Yeah.
And so this will hopefully stay attached.
That's good.
And it's funny though, like I've responded to those bike accidents already.
Mm-hmm.
And this is kind of
That's right. Because you're doing ABC. Like that's the thing you don't realize. That'll be important for the hospital.
Yeah.
But you're so busy managing and C-spining and treating, you don't have time to be like, what's their next of kin? Like, we're not worried about next of kin. You up?
yeah.
Look at them. These lights suck. See if you can find that call, Kyle.
Yeah, I guess the thing is for. Paramedic was 5 rings.
The what?
I guess for legend. I guess they. They were sent a different order, like site 8 years. I guess he was. I guess from outside he was acting as Iowa stuff.
Was it?
Colorado.
Much. Did you have another, like a first reaction to it or what? All one? Sometimes that happens.
The city. I did. Maybe they give too much.
That can happen. I'll see if I can- We should take a minute to kind of go through the major court cases that do cost people lives and or time in jail and money. 'Cause most of them you're like, oh, well, of course. Like this is the one when it's a hard debate between whether or not they did something right, and you can clearly see the EMT or the medic was acting on the best interests of the patient just to make sure. Those usually ended in being dismissed. And a lot of times, in the case of a friend of mine, So I'll tell you this story. I was in Oakland. I just really started. I started with this actually. There it goes. There we go. Okay. So I started working in Alameda in 05. Oh, 05. Yeah. Where's my how do I here we go. Okay. Anyway, I started in AMR in like 05, new medic, went in with another medic. We're both in our like early 20s. I was late 20s. He was early 20s. The medical director said, here's the deal. I know these are the rules. We went over medical legal, and he said, you might come across these patients that are in real dire situations. They don't want to go to the hospital. They're adamant. A lot of elderly patients back then were like, my friends go to the ER and they never come home, and I'm not going. It's like, there's almost a superstition towards it. And he said, listen, the medical director, if you see something that is legitimately a life threat, and this patient is adamant about not going, force them, strong arm them, do whatever you have to get them to the hospital. And, we said, well, isn't that it's kidnapping? And so he's like, yep, it will look like that first. But every call that I've been on, every court case of people in my county where there's a paramedic or an EMT up in a court, it's for things that they didn't do, that they should have done, but didn't. It's for the patient that they go, well, he's ANO4. He should go, but he's ANO4 technically, so he can sign his own refusal. They sign the refusal. They go home. Next morning, family members call, and the patient died that night. And then they find out that you were there that night earlier, and you checked him out, and you said he was good to go and cleared him, even though you saw with the vital signs and the chief complaint that there was something life-threatening, and you let him go. Those are the cases that people lose licenses and people end up, having to pay. Usually it's just you lose your license and you get fined. But so we were working in Oakland, and he pulled in after we were there running at Highland Hospital. He comes in with a call and brings in a resuscitation. They're working this guy up doing CPR, and they bring him in. And then police start pulling in. All these cops start showing up. And we're like, what the hell's going on? So they must be bringing in something serious. The medic comes out, and the police officers grab the medic and put him under arrest. And what had happened was that he was on a bus in Oakland with this patient who was showing VTAC tombstones. He was passing out. His blood pressure was tanking, and he was fighting the medic, saying, I'm not going. And he was like swinging at him, and the medic went, okay, I'm just going to wait. And he waited until the guy started to stagger. They put him up on the gurney, and they hauled ass to the hospital. The fire captain was freaking out that it was a kidnapping call, and he called the police and told them that the paramedic had just kidnapped the patient. Meanwhile, he goes to jail. The patient lives. This goes to court. Guess what happened? Huh? Medical director had his back. Not only let him go, he got a commendation because he stuck to his guns and did what was right. And clearly, if you're in the jury and you're like, this is what was going on, he was dying. He didn't want me to take him, and I took him anyway, and he lived. What law did you break in that? Did you break a tort law, or did you break a rule of like humanity? And if you can kind of, and the way I've always heard it is like, if you can hold your head up and tell the jury what you did for the right reasons that you did it, this was to keep the patient alive. And yeah, I might have overstepped my bounds here, but we clearly saved a life. Or we don't know what would have happened. Maybe he would have died if we left him at home, but I wasn't going to take that chance. It's a life threat. I see clearly from the signs and symptoms as a medically trained professional This is something that scared me if we left them. So we decided to take the patient. Maybe it was against their will, but the alternative was much, much worse. And if you can say that and mean it, like that takes a lot of courage to be able to do that. But that's the right move, in my opinion. Morally, ethically, that's my belief that you should be operating under that kind of law. There might be some medical directors that wouldn't have gone to bat for it too. So what do you do then? I would still follow my heart. Yeah.
What percentage of patients?
Not a lot. I mean, that actually, Busy County, I mean, you have to remember, a lot of times they refuse because it's not a life-threatening emergency. You get there and it's like, they're fine. So we are obligated to take a patient. If they've twisted an ankle, they fell and hit their head, but there ain't no and there's nothing we're seeing that, people fall and hit their heads all the time. You're not seeing anything serious. We still are supposed to take them to the hospital, but I'll feel comfortable if they sign a refusal, especially if there's somebody there that can watch them, especially if somebody can take them to the hospital or call us again if anything starts to become a little bit unusual. But most of all, based on the signs and symptoms, the vital signs, the way the patient's presenting, the mechanism or the nature of illness, it's not something that really makes me want to force them to go to the hospital. Makes me really want to urge them to go to the hospital. I shouldn't say force. Then I let them sign refusals all the time. Yeah, if it's not going to be to their benefit, I don't know. Why would we make them go? It's a $5,000 car ride. And they're not, you're giving oxygen at $50 a gallon or a liter. It's crazy how expensive it is. So they don't have to go. I'm not making them. And that's how I justify if they need to go, I'm going to find a way to get them there.
How often would it see for like fake CPR for someone's ribs?
I've never heard of a case where that happens. Because you have to remember, breaking ribs is like part of the game. That just happens all the time. How do I get rid of this thing? How do I move this thing out of the way? Huh? Get out of here. Thank you. Yeah, you break ribs. That's part of the game. They tell you that you're going to break ribs doing CPR. You're going to at least separate ribs. They'd rather have broken ribs and be alive than have a perfect ribs cage and be dead. There's no reason. That is the emergency doctrine of the Good Samaritan clause, is you might do a little bit of damage or things might be incurred in the process of saving someone's life. So there might be minor damage. Sometimes with the tracheal intubation, you might kind of scratch the larynx and or the vocal cords and cause hoarse voice or injuries and things. You can litigate that stuff, but if it happens in the process of you following your protocols, that's just, that's, what was I going to say? It's a casualty of the job. It's kind of a casualty of how we have to operate. It's a little barbaric still, especially when you watch orthopedic surgeries and things. Like, it's still pretty barbaric. All right.
Your screen.
My screen is not pictured. Okay. Better? That's what you meant?
Says your screen sharing pause.
Uh-oh.
Zoom.
Yeah, it's
Thank-
a little stuck.
Thank you, gang. Thanks. By the way, again, I'm new to this whole thing. So if you see anything, please. This is probably most of your wheelhouses before. Offices and dealt with this stuff a lot more than I have. So good. Uh-oh. All right. So advanced directives, you might also hear them called living wills, healthcare directives. In the DNR, for it to be legit, they have to have the patient's medical issues. Usually they're terminal. It has to have the signature of the patient or the legal guardian if the patient isn't fully capable of making those decisions, senile, Alzheimer's, etc. And it has to be signed by a physician, and it has to be current. Ideally, it's current. What do you do if it's like a date, if it's like a month out of date? Hopefully I've taught you a couple of things thus far. Do you have any gray areas? What should you probably do? Call medical control and say, hey, this is 3 months out of date, then you have to take the situation under consideration. It's like, okay, they're a terminally ill patient. They're in bed. They're bedridden. They're dying. This thing, they didn't get to the doctor in the last 3 months because the patient's been withering away and dying in the bed. And so they didn't renew the DNR. Is there any reason why now they would say, no, thanks. I don't want to. I want you to treat me now after having that thing for a full year and saying, by no means should you try and resuscitate me. Now are they going to come around and get upset that you stop treatment, even though it's like a month out of date? That being said, you should document everything there and get somebody at a higher level to concur with your thinking on that. And it's not uncommon. It wouldn't be unheard of for an EMT to bring that patient to the hospital and say, the DNR had expired. I didn't know what to do. So here, and the hospital's going to go, okay, next time call base. They're going to try and run a couple of rounds on that patient and they're going to pronounce the patient. And now it's their responsibility to manage it, which is just, they don't want to deal with that. It's not patient that they have a chance of saving.
How long are DNRs typically after?
A year.
A year?
Yeah. So you have to do it after a year. You should go get it. Same thing with this pulse or most. That's more like deciding specific care that you want, what care you wouldn't, feeding tubes. Do you want to be on a respirator? That kind of thing. They're describing the acceptable interventions for the patient. Again, has to be signed by an authorized medical provider. And if you have any questions, just contact somebody else. Call for a lifeline. There's no harm in that. Here's a couple examples of DNRs. So they're clearly colored. They should stand out when you show up. They should be in an obvious place when you show up in the houses. They're supposed to be on the front of the clipboard or like next to the beds or as you walk in the door right there so that there's no question about it. Does that count? A lot of people, not a lot. I've heard of like 2 people have actually come across a patient with this. One of them was a Hell's Angel.
Blanked out part. Is that like a picture?
I don't know what it is. It might be somebody's name or something, but
What's that name?
what if there was a name, right? What if it, and there's a physician signature and a notary stamp? That's the, yeah, I would still try and find the actual written documentation. Okay. So now if I came across somebody with this, I'd be like, well, let's look for DNR somewhere then. Clearly, they went to the extra mile for us to go, hey, I have one of these just in case you want to check. That would be kind of bluffing and kind of cowardice if you had that, but then you didn't actually have it yet on.
It'd be a little while.
Yeah, it'd be a little, it's a far-fetched, kind of a braggadocious move. Here's some advanced directives. Again, just note the color of them, how easily they are to see. What do we do for organ donors? Treat them like regular patients. Don't worry about it. Where do you find this stuff? They're usually an organ donor card, or there's that little sticker you can put on the driver's license that says they're an organ donor. We were just talking at break. You have a little ID tag on your watch in case you take a stack and you're riding the bike. I can't tell you how rarely we are actually pulling out wallets and looking for organ donor cards or somebody's information on their IDs. Like that's not our drive. Our drive is to stabilize airway and breathing and circulation, strap them up and get them to the hospital without doing any further damage. And then as you're going, you're like, let's see. And you look and you're like, okay, this is James Joyce and he lives at Dublin M. And you put in like that. Now you get some information. That's really for the medical bill. Or when you show up on the hospital ring down, when you show up to give the handover, you say, this is James Joyce's birthday. It's 11/18/27. He was, catatonic when we were on. Blood pressure was this, pulse was this, respirations to this. We found his R2 sat was this, and you go through the litany of what you've done. But those hospital staffs are writing down the name and the date of birth and looking to see if he's a patient at Marin General or if he's a Kaiser patient and how they can get further information on him. It really doesn't affect our care of a patient. So with that in mind, that's all we're really worried about. I don't care. I never know if the patient's an organ donor or not. Remember that organs need oxygen. They need resuscitation. So if the patient's dying, we want to keep those organs viable as long as possible to get them to the hospital for that decision to be made. There's an organ donor card. Anybody have an organ? No, that's not a HIPAA violation, but most people, if you're going to be an organ donor, you have a little sticker on your driver's license. Now, how about this? What if somebody, while dying, says, wait a minute, please ignore the DNR? We're going to ignore the, please, I don't want to die. Well, let's play that one out. Okay, we'll treat you. Or, I'm sorry, sir. You signed this back in January. Bye. Clearly, you're not going to do the second thing, right? Right? Treat the patient. Make sure you're treating the patient. All right, fair enough. It's a lot of this stuff is like very hypothetical until you're like, oh, of course, you know. So it's hard to kind of figure that out. We've mentioned the term power of attorney, and essentially that's somebody making the legal decisions and the health care decisions for the patient if they're not capable of doing it. Usually it's the wife. It can be if the patient has some kind of mental deficit and they're in a care home, it'll be the caregivers there or a guardian. It could be if it's an elderly patient, the older of age children of that patient are the legal guardians. And this comes into play when the patients we're treating are no longer, they're essentially, they fall under the category of failure to thrive. They're not making the correct decisions for themselves to stay alive. They're a danger to themselves or others. And so we need somebody else to step in and make educated, responsible decisions for the patient. So in those cases, we can have them sign the refusals. We can have them verify and witness the release forms or the refusals and everything else that we do. Or the, sign the paperwork when we pronounce on scene or something like that. Okay, so we fit on all of this. And I made sure you know that putting a patient in 5150 is putting them under arrest, right? Or arresting them for that. 5170 is the same thing, danger to themselves or others, but with intoxication of some sort on board, usually chemical intoxication. Let's get into the signs of death. When do we call? When do we decide to work up a patient that only looks dead, who's mostly dead? So presumptive death is they're not in good shape, but we get there and there's some chance of them surviving. However, to most people, they do appear dead. As a paramedic, I can pronounce death in the field if, and it happens only if, two cases. We try and work up the presumptive signs of death on a patient and we get no response. So we do the CPR, we do the ALS care if we're allowed to, and we don't get any cardiac response to any of the meds or the treatments. Then we can pronounce in the field. Or there's definitive signs of death. And if there's definitive signs of death, we don't even bother working them. They've been dead for a long time. So first, the presumptive signs of death would be unresponsive to painful stimuli. So we do the shake and shout and there's no response. There's no pulse. We start CPR. Clearly, if there's no pulse, there's going to be no breathing. They don't have any reflexes in their eyes. You shine a light and the pupil stays dilated. There's no movement whatsoever. Some people, you can rub like the eyelids, the eyelashes, and you see the eyes flutter. No systolic blood pressure, right? There's no pulse, so you're not going to have a blood pressure. Profound cyanosis, lowered body temperature, but not cold and not room temperature. I've seen patients pink up like you wouldn't believe. Just they look like grapes. They're like blueberries when you show up. They're in complete respiratory arrest. And with just a few minutes of positive pressure ventilation with good oxygenation, they start to completely change. All of their skin signs get better and they start to come around, let alone for all the times that we've done CPR in early and they've brought patients back to life when they've been at the brink, when they've shown these presumptive signs of death, right? That's our job, is to hopefully get there when they're just presumptive and not definitive death. There's a big old, I don't know if that's a dead patient or really alive experiencing patient. Some signs that we can shock the patient would be, this is ventricular fibrillation. This is what the patient was in for my friend and the patient in the bus. He'd go into these runs of VTAC. They call these tombstones for good reason. And it simply is it's the ventricles freaking out, panicking because they can't get oxygen, and they're beating as fast as they can. And eventually they run out of any oxygen because there's a big clot stopping the blood to get to those cells. And the ventricles are beating so fast, they don't open up enough to allow any filling of blood to pump to the body. And people just start to pass out because they lose blood flow to the brain. And then pulsing ventricular tachycardia becomes pulseless. And that can turn into flatline, asystole, or ventricular fibrillation. If we don't get them back from VFib or VTAC or VFib would be like the fine lines, they go eventually into flatline. This is what flatline looks like, by the way. It's not 100% flat. It's just no electrical impedance and the signals going through the body, finding its easiest way through as a current. So it's a little bit up and down, but there's no little bleeps and bloops along the way. Definitive signs of death would be this. This is what we call dependent lividity. So as you die, all of your muscles eventually relax. That includes your bowel muscles. So people oftentimes defecate. If there's anything inside their bowels, it's going to come out. They urinate. And the muscles around the arteries just relaxes and completely they open up. The blood drains out and the blood sinks down to wherever the patient's laying, whatever part of that body is closest to the ground, whatever the weight of gravity is going to take that blood, it just pools down and starts to seep through, and you see it in the skin. It's essentially what a bruise is, but with bruises, we've broken those blood vessels and the blood spilled out. With this, the blood vessels systemically dilated and the blood just leaked out. So this patient was probably, based on what I can see here, laying on their bed supine because the blood was pushed out of the buttocks. So they were sitting on it. It collected in this little area that stopped pressing against the mattress. And somebody went, hey, we're making this book for AAOS. Hey, Gary, will you lift the patient up? I want to show a picture of dependent lividity. And Gary went, okay, pushed him up. And there's Gary's fingers right there. That's what you're seeing right there. That's not a bruise or anything weird. That's a person's hand that just lifted the patient. Okay. You could get this if they were laying like this when they died. It would be dependent lividity all down the left lateral part of the body. It would all pool on this side of the body. So depending on how they're laying, you're going to get a different shape and coloration on the body from dependent lividity. We're not working up anybody who's dismembered, core torn apart. These are all going to be pretty self-explanatory, I think. Decapitation, good luck. Incineration, somebody caught in a fire that just gets toasted. Rigor mortis, body stiffening. So as the body tissues start to die, toxins build up, and I think the real reason the muscles, they stiffen up. And it's because of the irritation of the acids that are being released from the dead cells. And as that irritates the tissue, it starts to clench up the muscles. And so they kind of get into this position where if they're laying like this, the muscles just tighten up in that shape. So you lift the patient up and they go like that. Okay. You find rigor in the arms and legs and the jaw and neck, first and foremost. Usually happens around 2 to 12 hours after death. So if you find rigor, where's our window of saving somebody's life? How many minutes do we have? Like 10 minutes. Let's just say 10 minutes on a viable patient, on a really strong hardy patient, 10 minutes. There's no way you're bringing back somebody from 2 hours. It's just that the tissue's dead, the toxins have leaked in. We're not going to work somebody up like this. So one of the first things that I do when I go on a call like this, is you walk up and you try and move the jaw, you move the neck, and you feel the temperature. So if you find any rigidity, where if I was going to put an OPA in and on like that, and it's staying like this, forget it. That's it. That's rigor. If you go, and they move and the tongue moves out of the way, you're like, okay, we're going to work this person up. It's not rigor's not set in. Same thing with the arms. If you push the arms and they flop down, we're going to try and work them up. If there's any resistance, chances are it's rigor, and we don't have any chance of saving. Allegor mortis is cold, cooling of the body, room temperature, cold. Until you felt that, it's a weird sensation to feel a human that's cold like that. You'll know the difference between, oh, they seem like chilly and cold from the weather to like, oh yeah, that's like room temp. That's been a while for that to set in. And then the last ones, which are clearly not going to be worked up, are putrefaction, when you're essentially decomposing. Usually it happens around 2 days and longer, and your body just starts leaking out and just moldering, dying, festering. Bacteria starts to grow in there. Even more interesting are when these people have pets. No one's fed the pets for a few days. They find something to eat. Oftentimes when you find these patients, it's because somebody smelled them before they thought they even checked them. So like a mailman comes by and they're like, something's dead. You'll know it's putrefying, dead organic tissue. It smells like, dead, dying infections and farts and everything. You'll know there's something wrong if you ever smell something rotting. And it's a lot of tissue, so it stinks. Okay, so when do we have to bring in a medical examiner? Well, anytime we're considering it a weird situation, there's some sketchy things going on with the call, or otherwise it's a normal patient that shouldn't maybe have died the way that they did, or from the circumstances we see. So DOAs, dead on scene. In these cases, also remember, I should say, we're notifying PD, or PD is coming along with us, and PD will notify the medical examiner for these calls. So when you show up, you want to make sure that the police are on scene for all of these resuscitations, even if we don't work up the patient. And once they are, if there's some weird situation, they're going to then send out the medical examiner to investigate. The medical examiner is like an investigator, a detective of dead people and like scenes of the dead, to figure out whether or not there's something nefarious going on, or to document the case and kind of have this all, on record. So medical examiner shows up, they're looking at patients that have died, but more so like without any previous medical issues, suddenly there's a dead person. We got to figure out what are the underlying factors for this. So autopsies are going to go through and try and find out the big things. Suicides, violent death, like car crashes on the freeway, boating accidents, weird situations like people drown or get chopped up. Any of those definitive signs of death, like dismemberment and things, medical examiner needs to investigate, find out the mechanism behind how that stuff occurred. Any poisoning or suspected poisoning, any death from accident, suspicion of a criminal act, more or less like in the act of a felony or in the act of like a major drug deal or something is when police come into play. We rarely, for an overdose patient, do we need PD on scene, but you'll see like in this, it says they should be notified. We need to file the paperwork for any drug related emergency, but that really doesn't entail the OD, certainly not the OD fentanyl patient. They come in and out of the ERs and we document them on a PCR. But we're not sending that information up to PD, and we're not sending it up to the different agencies that come and get these people help. It's simply too many people, and we're inundated with that, and it's kind of part of the job. Sorry, I digressed. Anyway, infant pediatric deaths, any of your SIDS cases. Let's go through the scope of practice. What is scope of practice?
What you can and can't do.
Good. Can and can't do. What your what? Yeah, what your knowledge of your job is, what your protocols are as an EMT versus a paramedic versus an EMR. Like, what is your scope of practice? What are the tools? What are the skills for assessing? What are the tools you have for assessing? What are the treatments you have allowed for you to treat the patient and stabilizing the patient?
Are you most importantly what you're legally authorized?
Legally authorized above it. Yeah. When it comes to this subject, absolutely. Because if there's someone who steps outside of their scope of practice, you can be charged with negligence. So we want to find out what exactly that entails. And it's pretty in depth. So you'll see if in any of those situations they can't prove negligence, you're clear. And if you're providing for the patient's well-being, chances are you're not going to be charged with negligence. Standard of care. Is there a difference between scope of practice and standard of care? What is it? That's good.
Standard of care is like the standard of how you should.
I like it. That's great. Like what is expected of yourself and your person as an EMT? You could still follow the rules and just be a pain in the ass and like not be a good EMT. Do you go the extra mile to check for things that aren't obvious? Do you, if it's a question of C-spining or not C-spining, and you can go either way, do you go and say, let's just C-spine that? Because yeah, let's just clear and make sure it's best for the patient and we don't get in any trouble. That's your standard of care. Are you operating at a level of excellence that you would be proud of, or somebody else who maybe their family members hurt? Are they going to want you on scene taking care of their family member? That's the standard of care, is that excellence you will hold yourself to. Online versus offline medical control, or online versus offline protocols. What's duty to act versus scope of practice and standard of care?
You have to be responsibility to give credible patient.
Okay. Yeah. Duty to act really comes when you are working as an EMT in a job where you're expected to respond, perform at a standard of care of excellence, and follow your scope of practice. And you don't make any other bad decisions like leaving the patient on scene or leaving him in the hallway of the ER because you got to run off to another call. If you do any of those, that's abandonment. So now you're talking about leaving a patient without somebody providing for future care. Yeah.
Your experience, like being on TV in any company, people down with
Yeah. What do you think I do? More Ricky rescue, man. Especially now that I don't have the opportunity to work in the field. I stop all the time. My parents, I don't know if you know the story of my parents, like, you know, they're steeped in this whole job too. My dad and mom met in an EMT class in San Francisco. And they're firefighters and nurses, and they would stop regularly with my brother and me in the car, and they'd be like, stay in the car, and they'd go and respond and work on people, and then get in the car and drive off. And that's just how I grew up, was doing that. So I just assumed I would do that always. Now, there are situations where you may not want to do that. Like what? How about a car accident on a freeway? That's terrifying. Don't get out of a car when there's people zooming by at 90 miles an hour in the middle of the night and thinking you're safe to go out and be a hero. Like, you have to consider your own safety. I've come across like somebody who got hit on a scooter while I'm driving to come to class to teach. And I just get out and talk to the person, get them calmed down, do a quick assessment, and then PD or fire shows up, wait for fire, and then hand off and then come to class. That's fine. Make sure your safety first. With that in mind, do we have a duty to act if we're off duty? No, you don't. You're not legally obligated to do that. Maybe you consider yourself morally obligated to do that. That's cool, but you're not legally obligated. Once you start treating a patient, do you have a legal opportunity or a legal obligation to stay? Yeah. Once you start care, now you can't discontinue care until someone of your training takes over, or hired takes over the continuum of patient care, of survival, that chain of survival. So you have to ensure, because that's what we know is what keeps people alive, is getting them on that chain of survival. And then we can dip out when somebody else is going to take that person to the next level and move them on down the line. So with doing this, most people that get in this job are going to be the ones that stop and check. All that being said, I've heard stories of guys that are like telling me they're on a plane going to Mexico, and the guy next to him croaked out and he was trying to hide so he didn't have to do mouth to mouth on him and treat him. I'm like, bro, you've been a firefighter for like 25 years. Like, really? They got the defibrillator and everything. He's like, I just don't want to get involved. They're like, that's what you do all day here. Or maybe you don't. This takes all kinds of people. So do what hopefully you would, if it's safe enough, you try and step and make a difference. You know, at the very least, don't be the one filming situation and being like, oh, look how bad this is. I'm putting this up on Insta. Don't do that. Do something beneficial. And once you do, realize that you're there until somebody else goes by. So scope of practice is dictated by state law. The NREMT is where we get all of our scope of practice done. And then based on the scope of practice designed by the National Registry, that filters down into something called Title 22, which is the stipulations for starting everything from an ambulance company to a fire department, a hospital, a training center, how you teach EMT, paramedic, all this stuff that's the Title 22 of California. But all of that is basically the same information that the National Registries provide. So our scope of practice is the same as anyone in Arkansas's EMT scope of practice is the same as anybody from Mississippi or Chicago. The medical director steps in and says, I trust this system. I want to be the medical director. I'm a doctor, and I'm going to put my license on the line. I get paid compensation for it, but these EMTs and medics will be operating under my medical license. And so with that, I get to decide some specific treatments that I would like to have my EMTs do. They're not going to be crazy things like you're allowed to start IVs and give epinephrine, because that's not your scope of practice. But it might be, hey, we have to decide that we can decide between giving Valium and midazolam or Versed. I like Versed. As a medical director, I'm going to decide that anti-seizure med that we carry will be Versed and not Valium. So you can kind of tweak your specific system a little bit as a medical director. That makes sense. My medical director was the one saying, like, bring him to the hospital. If you have to force him, do it. I'll get your back. Some medical directors would say, absolutely not. That's not how it works. Where I will go to bat if you do that. We have online and offline medical controls. That's basically base is online control. Whenever something doesn't fall into your offline medical control, your standing orders, your book of protocols, which you'll get when you start working in an agency. We'll give you a binder with all of the protocols for managing every single conceivable medical and traumatic emergency you go on. And it will be a cookbook. And it just tells you, BSI, scene safety, look for the number of patients, it runs the patient assessment, and then says EMTs, basic life support care, provide C-spine, check ABCs, check vitals, get oxygen on the patient, and then end there. And then it'll say ALS care, if needed, start IVs, give medication, give IV, give fluid, and give it at this drip rate. And it will totally give you the whole rundown on how to manage traumas, respiratory arrests, and it's an algorithm. And if you think it's infection, go this way. And if you think it's cardiogenic, go this way. And this is why a lot of medics do very well if they're a little bit just by the book and they can follow the rules, because it's a cookbook and you can just study and learn that, memorize that, and you're pretty much covered. But then those weird situations where you have to kind of go on your gut feeling, or you at least it's ambiguous enough that it doesn't fall into the offline stuff. You can call base, get online medical control and say, here's what's going on. I was going to go down this channel, but I'm worried that that might make it worse if it's this other thing. What do you think in your opinion? Most of the time, the medical base agent will say, well, use your best judgment. And that's all they really tell you. And you're like, okay. All right. So let's go with this. Document that you contacted base, the information they gave you, the route you went through, the justification for it. And then let's see what happens to the patient outcome. There's no reason why you can't start down one path. And as you're reassessing, if vital signs are getting worse, you can discontinue one of those treatments, try something else, right? That just shows your heads up. You're not going to always be right when you do jobs. So you kind of have to fish around and go, okay, well, let's get the things covered that we can. And then let's assess a couple more things. And maybe we try this. And if that makes the chest pain worse, then don't give nitro anymore. It could be maybe they're having an aneurysm. They're not having a heart attack. So stop the nitro use and let's go down the aneurysm path for a while. So that'll make more sense when we go around with. Anyway, keep in mind that you are allowed some leeway to try different things out based on the ambiguity of the call. First, call base, tell them what's going on, and if they still don't have a definite answer, try one or two minor things and see what the outcome is, and then pursue whatever direction that leads you. And that would be handling your online control. Whoops, sorry. Okay. All of this stuff is stream from the culture, from the infrastructure of that area. For instance, like when I worked in Afghanistan, we didn't have defibrillators. They couldn't afford them. And if you were responding to a remote location, you'd get there and then you'd have to travel like 40 miles over dirt and sand and you'd get to a hospital. There was just no way to keep that patient alive. So the ambulances there didn't have defibrillators. It was kind of like, well, you died and that's it. You're dead. You could do a lot of first aid stuff. It was very trauma heavy. And that's based on the logistics of that area, whether it's the infrastructure of that place. Local customs, who's going to be on the ambulances? There's not a lot of females working on ambulances in Afghanistan. So then how do you manage maybe someone who's having an ectopic pregnancy and you're a medic trying to manage that and they don't want men treating women, but there's no trained females to manage that call. That can be a bit dicey. So laws and codes kind of fall, they're downstream from that. And you can see this is why in so many ways we've really integrated cutting edge techniques and treatments in our culture. And it really does do for everyone. It seems to have a benefit, in my opinion. Okay. So we're following all of these rules and things that we have set up are based on National Registry rules and regulations. American Heart Association guidelines for proper CPR. And, for adults, 1 rescuer, 2 rescuers, children, 1 rescuer, 2 rescuers. We're just kind of falling in line with those regulations. And that will change over the years. And then we adapt with those and see if anything changes with the patient outcomes. If we get definite positive outcomes, we stay with that modality of care. We stay with that protocol and that treatment line. If we're not seeing good benefits, if there's no efficacy to it, we'll go back to the old way or try something else. And that's kind of how we walk through this. Okay, so I talked about being negligent. What is that exactly? Negligence is going outside your scope of practice in one way or another. Sometimes it's you doing stuff you shouldn't be. Sometimes it's you being lazy. Sometimes it's leaving a patient on scene that you didn't think needed to go and they end up doing bad. And, we have to figure out what is entailed in negligence and negligent behavior. But if an EMT is convicted of negligence, you can be convicted of criminal offenses. You can do jail time. You can pay a monetary fine. It's rare, unless it's something that's pretty malicious or devious or obvious. The more ambiguous, the harder it is to convict. So in order to persecute negligence, there has to be these 4 things. There's a duty to act. The EMT or the medic breached it in one way or another. There's a breach of duty. You went outside your scope of practice. You didn't fulfill your scope of practice. You stopped early. You should have checked for something that you didn't. And you should have known to check for that. It's part of the protocol. It's in your standing orders. There's no excuse for you to have missed that. So there's a breach of duty. There are damages that were incurred by the patient. And most importantly, they can take your breach of duty, your deviation from the scope, and show causation to the injuries that were incurred by the patient. And that's what that whole trial's for. To show you should have known better, you did this instead. That caused damages, and we can see the causation between what you did by stepping outside your obligations or your job and what happened with the patient, the outcome to that patient. They're just talking about one where a medic got charged for gave it what, like some kind of pain med, and then knocked the patient out and give a sedative to a patient. That's all still on the up and up. Where it starts to get bad is if they gave the wrong sedative, or they gave something that they should have known was going to have an alert, a bad reaction for the patient. Or there's other circumstances in there where they should have known based on the vital signs that this patient wasn't going to handle the amount of sedative that was given. Sometimes, I mean, and this happens, believe it or not, quite often. The wrong medication is given in the hospital. It happens all the time. Even in our little drug box, they have these, they look exactly the same, the morphine and the Versed, and they're just a little bit different colored. And if you're trying to manage a patient that's having a seizure and you're trying to manage the airway and load up the vial, if you're not like going, boom, Versed, serial number, like while this is going crazy on you, a kid's seizing, mother's freaking out, and you're going through and making sure you don't grab the morphine and pump them full of 5 milligrams of morphine. You instead, you do it the wrong med. You give them the morphine and not the Versed. This kid goes bad. Potentially you're in big trouble. And even then, if it's a legitimate mistake like that, most medics don't lose their job. Maybe if this goes to court and it's a major court case, now you're probably in danger of losing your job. But a lot of times, if there's no real adverse side effects and you cough to it, you just have to go back and do some training or something. It's very lenient. I mean, it really is. You have to understand it's a high stress job and mistakes are common in high stress jobs. That being said, this is why I stress on standard of care, because we have to be thinking beyond our stress levels to manage the overall problem. It can't be about us getting in the way of the patient. And if we're being careless or tired, or God forbid, you're being malicious towards the patient, you're going to cause a lot of damage and you're going to ruin someone's life or lives. All right. So if there was like a willingness to harm the patient or hide the information or disregarding the patient's safety, brazenly, the patient was hit by a car at 40 miles an hour, you throw them on the gurney and they're like, I can't move my legs, and don't worry about it. We'll get to the hospital. You don't see spine, you don't provide for care. You should know better. You brazenly disregarded safety. That's gonna come up in court. That's gross negligence. So remember, did you provide the same kind of care that a person with your similar training would provide in the same or a similar situation? Did you provide, as a patient advocate, the right kind of care for that person? Coerced abandonment is leaving the patient either on scene or at the ER, not making provisions for continuing the care. So those are the big places it typically happens. Somebody shows up on scene, they leave early, and the patient is now suffering because they didn't get packed into the ambulance and taken off to the hospital. Or we showed up, we did a couple of things and then left, and then nobody else came to continue the care. We're in the ER, it's crowded. Dispatch is telling us there's 5 calls that are waiting for an ambulance. You got to clear and come, and you fall prey to that stress and just leave your patient in the triage area or with somebody who's not trained, and that person has a seizure or dies or something. You're busted. That's it. That's abandonment. You've left that patient with somebody unqualified or nobody, and now they have suffered consequences for it. So I'm seeing at the ER, always get patient signatures for everything. And if possible, get witnesses to sign for this paperwork too. We mentioned assault. Assault is threatening somebody or putting them in restraints. Battery is unlawfully touching patients. And this is for patients that are A&O and they don't need to go, but we're forcing them to go. Okay. Good. Okay, so libel, slander, those words, right? Libel is writing something false down, slander is saying things wrong or lying intentionally. Where would that most likely occur in our job? PCRs. So make sure you're documenting everything that you do. If you don't document, it didn't happen. We've talked about this. Okay. Just make sure that you've done the reasonable help that you should to manage these patients. Okay. You act in good faith without expectation of any compensation, and you're within your scope of training. And you're not going to get busted for anything. A couple of things to keep in mind. We mentioned before, like, what is your department's standards? What are their customs? What's their culture? A lot of times you put stuff on social media and you're wearing your shirts, bless you, or you're wearing, as a firefighter, this is how I feel. You better be very careful about using platforms, wearing the material from another agency or department while you do so. Because what you are expressing is not necessarily the views of those people that you work for. And while free speech is protected, your job is not. So I just, as a matter of cause, be aware of what you're putting up on social media now. If you're, and it doesn't have to be like, I've already mentioned this, like, don't be out drinking and like showing people like, yeah, look how blacked out I was. It's not a good scene for an employer to look at your side. Okay, that's who they are. Huh? Also, this is a big one. St. Patty's Day parades. Most big fire departments, they send a grip of firefighters every year to Boston, Chicago, New York, San Francisco. And it's a big St. Patty's Day parade. It's wonderful. You wear your Class A's. That's a Class A, by the way. You wear your suit and tie and your badge for your department. And you go and you hit the bars after you do the parade. And most of the time, big departments, because it's been around for hundreds of years, it's like, yeah, do that. Represent us when you go to San Francisco, or when you go to New York. Some smaller departments like Tiburon, Southern Marin, they're like, if you get caught in your Class A's with the alcohol in your hand, you're fired. Like, they don't put up with it whatsoever. So know the policies of your agency where you go out there and show off. Look, I'm a firefighter too. Whereas we're not going to play this little scenario. This is kind of what I read earlier. I want to get through all of this stuff. What are we legally obligated to report? Obviously, any abuse of children and elderly, any commission of a felony, any injuries occurred during violent felonies, drug-related injuries, drug-related, like in the midst of a drug deal, something like that. Childbirth, you got to make sure you document the new people coming into the world. And then things like dog or animal bites, because you can pass on infections and things to people. Communicable diseases, new ones, big pandemic stuff, particularly virulent infections, COVID, tuberculosis, meningitis, that kind of stuff. Those are really bad, dangerous diseases. So make sure you're processing this. By obligated reporting, what does that mean? A little tricky. So we are notifying the hospital that we're bringing this in, and there may be additional paperwork we have to file to make sure that this is getting to the proper authorities. If it's a drug deal that's gone bad, it's ATF hearing about it. If it's child abuse or elderly abuse, it's Child Protective Services or Elderly Protective Services hearing about this and then furthering the investigation, that kind of thing. And any kind of domestic violence, sure. Take it seriously. Remember, you may end up in court not as a plaintiff, is that it? No, defendant, but as like a documentarian, like a historian that was on a call, and one person suing the other company because they were hit in a crosswalk. They have a PCR, and that's the only information they have of that scene, and it's your PCR. So they call you up and say, you're going to be asked to come up in front of the court in 2 weeks when this trial comes to court and explain what you remember from this call that happened 10, 15 years ago sometimes. So when you write your PCRs, be aware that you may be called in on the oddest of calls when you least expect it, years down the line, and you may be asked to be a historian and like review that call. If that happens, you should notify your shop steward, your union delegate, the chief. They'll give you the PCR prematurely, right, or whatever, before the call or before the court date, and you can go through and review it and kind of try and jog your memory and like, oh, right, okay, got it. So that you have a better presentation when you show up in court. But realize that can happen as a historian for a legal issue. It can happen from maybe your partner's being called into court and you're a witness to them. All of that stuff is a bad situation. All right. Be aware of, at the end of all of this, these are the things that are going to redeem and preserve your career. What do you hold yourself to? Are you acting as the advocate for the patient? How are you trying to present yourself to the community? And that really is like every time you go on a call, if you get that, should I do this or do I have to? It's probably, yeah, I should do this. I have to. I need to do this the right thing. If it feels like things asking, you know, this might be, then do that thing and just don't question it. Do the thing that's the upstanding move. Otherwise, like, so interesting that last Wednesday when we ran that call, like people, I walked out of here like thinking that was a real call. Like imagining that and going like, so whatever happened to that guy? And that stays in your conscience. That was just a story I made it. And it still got to me. And it's because I've been on calls like that. And if anything, if you're like that and that got you like, God, I don't know if I did that thing. Imagine if it's a real call. And that's sticking with you through your whole career. Like, I should have done this today. You don't want to be doing that. A lot of times that's where the PTSD comes from. It's from like, I know I should have done this and I didn't, and they died. And I didn't even get arrested. Nobody even knows what I did, but I do. That's a terrible guilt to live with. Be careful with that. And really, it's best to just now decide that you're not going to be that. Just decide now, I'm just going to do what's right. No question about it. There's no hemming and hawing. And hopefully you get a good partner who allows you to do that. All right, let's do 10, 15 minutes, and then we'll come back and hustle through human body. Got it? Good.